the presentation of today, I have to say, obviously, thank you so much for your invitation. Thank you so much for everyone, girl. I'm very glad to be again in your meeting, and as always, I am here with enthusiasm and a genuine pleasure to share and spread new concepts in the health sciences. Today, I would like to introduce a very important topic for dentistry and as well for other health sciences. We are going to talk about vertical dimension, how to measure it, and how to relate it to the rest of the body, not only locally, but within the entire global system of our body. This is a brief summary of my professional background. For those who don't know me, I am Professor Di Rocca, Director of the RMP International School. This is an international institution dedicated to training professionals for all health sciences in the diagnosis and treatment of neuromusculoskeletal dysfunctions. I have been working in this field for more than 40 years, promoting this holistic and interdisciplinary protocol known as myofunctional postural rehabilitation, neuromuscular postural rehabilitation, and that is very, very important to understand. And today we will discuss how the craniofacial system affects posture and why it is essential to establish a mandibular central relationship and a vertical dimension in balance with the whole body. We will also see how this can be measured with the Posturometer, along with some clinical cases. We're talking about the dysfunction of the craniofacial system. This is a key because sometimes we forgot that craniofacial system is related to the rest of the body. The craniofacial system is composed for the cranium, the face, and part of the face is stomatognatic system. For this reason, it is incorrect to speak only about TMJ dysfunction. What we are truly dealing with a craniofacial dysfunction. A correct mandibular posture and an appropriate vertical dimension where we can build a functional occlusion will provide stability to our system and to the entire body. The tonic postural system, it is the regulator of the body's muscle tone. It relies on key receptors such as the oculomotor system and the foot support mainly. A dysfunctional craniofacial system is one of the major disruptors of static posture. This is why it is essential to control its proper function, ensuring that it does not negatively affect the rest of the body. Craniofacial dysfunctions directly alter one of the key postural receptors, the oculomotor system. Here we can see a general outline of this alteration. Changes in the mandibular posture directly affect the oculomotor function, which is why establishing a proper centric relation is so important. Through the hyoid system, the craniofacial system is connected to the rest of the body. Many postural dysfunctions are related to combinate alteration, among them the dysfunction of the craniofacial system. Let's now look at the correlation with static posture. How does the jaw position affect muscle change? A dysfunction of the craniofacial systems activates one of the central nervous system's protective responses to defend the TMJs, that is, bruxisms. These mechanisms first produce local dysfunctions, and over time, when it becomes chronic, it alters the posture of the entire body. TMJs occlusion and start slowly bruxisms, and slowly we create a descending alteration that can arrive until feet. Bruxisms, when we have danger in the TMJs, is a defense for the TMJs. Bruxisms start the domino effect that create chronically injuries to the whole body. A common misconception is bruxisms is caused by stress. That is wrong. Bruxism is a defense. Obviously, chronically is causing stress. Let me talk about vertical dimension and its importance. In this section, we will define the concept of the neuromuscular postural vertical dimension. That is the key. That is the key of our lecture today. This definition is essential to establish the clinical and functional baseline from which we begin and the therapeutic objective we aim to achieve. The craniofacial system have two vertical dimensions. The first is the neuromuscular postural vertical dimension, which corresponds to the physiological rest position that does not alter static posture. The second is the anatomical vertical dimension, which is the one we use to build and establish a functional occlusion. This concept was introduced in our school with the development of the integrated interdisciplinary protocol. The postural neuromuscular vertical dimension refers to the vertical position of the mandible in which there is not occlusal contact. This means we are within the so-called physiological free space. In this space, the muscles of the craniofacial system reach their natural baseline tonus, free from external dental interferences. This state allows the mandible to remain in a position of neuromuscular balance, minimizing the stress on the temporomandibular joints and promoting harmony within the tonic postural system. Recognizing and respecting this physiological dimension is crucial, not only for functional occlusion, but also for the global posture organization of the individual. It is the foundation upon which stable, long-lasting, and not recidivating rehabilitation can be built, particularly when approached through an interdisciplinary lens that integrates dental posture, neuromuscular, and the whole body. This is completely a physiological position that represents the natural state of neuromuscular rest. However, it cannot be achieved unless there is a proper balance within the body's muscle change. Each muscle chain, from the craniofacial region to the cervical spine and extending through the back, pelvis, and lower limbs, must be functioning in harmony. Any imbalance, tension, or asymmetry within these chains can be alter the mandibular posture and interfere with the neuromuscular resting position, and consequently disrupt both occlusion stability and postural alignment. Therefore, obtaining this ideal vertical dimension requires an interdisciplinary evaluation and often a global approach to neuromuscular reeducation, which includes addressing cranial, posture, and systemic factors. Only when the body is in a state of global muscular balance can be the mandible naturally assume its true postural neuromuscular position. That is why the first essential step in our clinical protocol is mandibular deprogramming. This initial phase is designed to eliminate muscle and articular interferences that may distort the natural position of the mandible. Through this process, we aim to gently and progressively guide the mandible into a centered and balanced position within the glenoid cavity. What we refer to as mandibular central relation. This is not a forced mechanical position, but a neuromuscularly supported one, where the condyles are seated symmetrically and physiologically in their most stable articular position. Achieving this centric relation provides the foundation for all subsequent diagnostic and therapeutic steps. It ensures that the vertical dimension we later establish is based on a mandibular position of balance, symmetry, and functionally harmony with the entire postural system. Once the mandibular central relation has been achieved, we can proceed to the next critical step, the search for the postural neuromuscular vertical dimension. It is important to emphasize that this dimension is entirely different from the traditional anatomical vertical dimension, and in most cases, both of them, do not coincide. The postural neuromuscular vertical dimension represents the functional vertical height that allows the craniofacial and postural system to coexist in balance without generating stress or imbalance in the muscle change. This dimension is not fixed or universal. Rather, it is individualized and must be discovered through a physiological, progressive, and gradual process that represents the patient's neuromuscular adaptation capacity. To determine this dimension, we carry out a vertical height recording, identifying the maximum height that the craniofacial system can be tolerated in the vertical axis without disrupting the muscle balance. This process ensures that we are not forcing the system, but rather accompanying it toward a state of functional and postural harmony, respecting the body's biological adaptation. Time is essential. Any attempts to accelerate this process or artificially impose a height may be lead to muscle compensation, articular overload, and therapeutic failure. In this stage of the protocol, it is essential to measure and validate the vertical height registration. That's why it's important, the posturometer. This clinical instrument allows us to assess multiple parameters simultaneously: the comfort of the patient, the postural comfort, the degrees of muscle tone evaluation, the relax of the global muscles change, and the spatial orientation of the mandible. Through the posturometer, we obtain objective, quantifiable data that help determine whether the proposed vertical dimension and mandibular posture are functionally acceptable and biomechanically balanced. This step is critical to avoid compensatory patterns or long-term instability. When the posture of the mandible and the vertical dimension have been verified as physiological sound, we proceed to create this registration to mount in an articulation and study in that moment where we can put the occlusion. During this phase of the protocol, it is essential to perform a precise measurement of the vertical registration with the posturometer. This instrument provides an objective and reproducible method to evaluate critical parameters for establishing the correct neuromuscular vertical dimension. With posturometer, we are able to access to the patient overall postural comfort, to the muscle balance of this patient, and to the stability of the craniofacial system. We have in that moment the whole body measurement. Once the vertical dimension and mandibular posture are confirmed, and they are stable, in that moment, we will be sure that we can create a good occlusion. Let us move to another next topic, that is anatomical vertical dimension. It is essential to clearly understand the difference between the two types of vertical dimensions we are working. Functional is the neuromuscular postural vertical dimension, and anatomical is the vertical dimension where we'll build the occlusion. This is essential to have a good harmony between craniofacial system and the rest of the body. At this point, it's essential to understand that anatomical and functional. If we have the combination of these two vertical dimensions in harmony with the rest of the body, we will have permanent rehabilitation in the whole body, local and total body. The anatomical vertical dimension is easily to determine, but it is important to understand that we have to compare functional vertical dimension, anatomical vertical dimension, and total body posture. Let us now analyze how, through an objective instrument, we can determine whether the correct position. Posturometric diagnosis is essential for this process. Let's make a brief introduction to posturometry and posturometer so you can understand the process. The posturometer we develop in our school allows us to objectively analyze the body's static posture, enabling us to plan and carry out a treatment in perfect postural balance. This is the posturometer. This instrument is based in the concept of Kepanji, physiotherapists, French physiotherapists who study the distribution of body weight on the ground through each foot. Posturometry allows to analyze the effect of the jaw position. We also can analyze if the pre-contact of the occlusion can alter the body posture. And it allows us to analyze everything we need to be sure we are in a good and perfect central relationship, vertical dimension, and good occlusion that will not disturb the rest of the body. One of the fundamental graphs for clinical interpretation is the barycenter position. The barycenter position we measure in a sagittal way. But most important than this is the value that you see there as BA. BA is the area of the barycenter, and this shows us in our measurement the muscle tone of the whole body, not just the local muscle tone of the craniofacial system. How is the muscle tone of the whole body? And we measure that with the mouth open first and the eyes open, and then with the eyes open and the mouth closed. And we will see the effect of the craniofacial system into the body posture. And that's very important to understand if we are in a good central relationship and a good vertical dimension. In that moment, we are sure our rehabilitation, our craniofacial system is not disturbing the whole body. And that is important to have good and lasting rehabilitation. This is important to analyze this barycenter area. Normally, interpreting that values and comparing the values, normally when we have a high vertical dimension, that is creating hyperactivity in the muscle chains of the body, and the value, when the hyperactivity is more, this value is less. And when we have a loss of vertical dimension, we create hypotone in our muscle chains, and this value increase. You see, with a simple measure, we can evaluate if the jaw is centrated, if we don't have any occlusal interferences, and also if our vertical dimension is good, not affecting the rest of the body. And that's very important, because normally we check that only locally. We check only in the craniofacial. It is important to understand how we can interfere with the rest of the body, because the body is a total universe. And we cannot measure only one part of the body. That is a real holistic approach. We see here a patient, open mouth and closed mouth, the values of transversal is equal. That means the jaw is centrated. It's not altering. It's a good central relation. If you see here, you analyze the varicenter, we see also this is the same. The green and blue is the varicenter. Open mouth and closed mouth are in the same line. That means jaw is good centrated. But if you analyze the values of the BA, you see when the green is mouth closed, the value increase. That means vertical dimension is less. That's why it's necessary measure our rehabilitation in the total body. We see some cases, and then is finished the presentation. This is obviously when we have a vertical dimension less, we see that patient. This patient is a patient who is. We did a rehabilitation, we did programming, we reprogramming, and we fix a rehabilitation of the total mouth. We tested the vertical dimension, we value the tested vertical dimension, and then we create the occlusion. That is the way. The same another one. This is another patient with mandibular deprogramming, reprogramming, and etc. We create vertical dimension, good vertical dimension, and then occlusion, and we measure. This is all for my presentation. This is our courses in our school. If you want to come to us to study, and this is my contacts, and I have to say thank you so much because for your attention, and thank you so much for your invitation in the meeting. Thank you so much, Marian, to invite me again. This is the final presentation for today. Thank you so much for your invitation. I hope the presentation was good for everybody.